بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا كريم. Dear colleagues, now we are going to discuss the issue of phacomatosis. And by phacomatosis, we mean that a group of diseases that share a specific criteria, and these diseases are previously known as neurocutaneous diseases. Meaning that most of these diseases, if not all, they have skin manifestations as well as nervous or CNS manifestations. There are a lot of diseases that share these properties, and I have selected the most common, frequently seen in the clinical practice diseases, and they are 8 in numbers. Also, we have other 10 diseases that are included under the title of neurocutaneous diseases or phacomatosis, but they are relatively uncommon and even rare to be encountered in the regular clinical practice. But I will discuss these lesions, including the neurofibromatosis type 1 and 2, the Ehlers-Danlos syndrome, Osler-Weber-Rendeau syndrome, tuberous sclerosis, ataxia telangiectasia, neurocutaneous melanosis, Lermet-Douglas Codwin syndrome, and the Sturge-Weber syndrome. The remaining 10 lesions are included in this list if anyone would like to go through any of them in the literature. We start by the most common one of this group, which is the neurofibromatosis type 1. And as stated here, it is a multi-organ autosomal dominant disease, and the incidence is about 1 per 2,000 newborns. And the disease encounters a spectrum of lesions in the CNS and also neoplastic lesions as well. These changes can be observed in about 70% of patients with neurofibromatosis type 1. We have, under the title of neurofibromatosis, we have 3 types: the neurofibromatosis type 1 and type 2, and the schwannomatosis. Each of these lesions has a different genetic etiology, but neurofibromatosis type 1 is the most common of the 3 conditions. And the pathognomonic feature of this type of disease is the presence of neurofibromas, which are scattered everywhere in the body, including also, of course, the skin. The children affected by neurofibromatosis type 1 may present by brain tumors, commonly along the optic pathways and also in the brainstem. 5% of patients with neurofibromatosis will develop a malignant peripheral nerve sheath tumor, which was known previously as neurofibrosarcoma. Then the prevalence of high-grade gliomas is about 30-fold higher than the prevalence in general population. The disease is also known as von Recklinghausen disease, and it affects the skin, of course, the CNS, bones, endocrine glands, and other parts in the body. Up to 50% of the disease can be encountered as sporadic lesions, and the neurofibromatosis type 1 mainly affects patients in the childhood period, and about 10% of the patients may present later on in their life. And according to this National Institute of Health, there are 7 criteria for the neurofibromatosis type 1, and at least there should be 2 of these 7 criteria in order to establish the diagnosis of neurofibromatosis type 1. The first is axillary or inguinal frickling, which means that you got abnormal skin roughness and color seen mainly in the axilla and in the groin. Bone lesions, including the sphenoid wing dysplasia and the pseudoarthrosis of the tibia. Cafe au lait spots, and these cafe au lait spots should have this criteria. They should be at least 6 in number and 5 millimeter in size in the prepubertal age, 15 millimeter in size in the post-pubertal age. Skin neurofibromatosis, as you can see, eye hamartomas, or what's known as leash nodules, which are small nodules in the iris of pigmented and different color. Then the family history of a first-degree relative affected by neurofibromatosis, or the presence of optic nerve glioma. These are the criteria: 6 or more cafe au lait batches, 2 or more neurofibromas, 2 or more leash nodules, optic nerve glioma, frickling in the axilla or the groin, and the distinctive bony lesions like sphenoid wing dysplasia. The disease has many manifestations all over the body, and these manifestations are classified into neoplastic and non-neoplastic lesions. The non-neoplastic lesions include the focal abnormal signal intensities. I will explain all of these. Hamartomas in the visual pathways, epileptogenic lesions, sphenoid wing dysplasia, ophthalmos, lambdoid suture defects, dural calcifications, dural ectasia, moya-moya phenomena, craniofacial alterations, spinal lesions, and musculoskeletal manifestations. The neoplastic lesions include number 1 and the most common, which is optic nerve glioma, juvenile pilocytic astrocytoma, brainstem glioma, spinal cord astrocytoma, ganglioma, and the malignant peripheral nerve sheath tumor. We start by the first stigmata, or the first criteria of the neurofibromatosis type 1 in the CNS, which is known as focal abnormal signal intensities. This means that in the MRI of the brain, you see some focal areas of bright signal in the T1 and T2 weighted images, and these signals are usually located in the cerebellum, in the brainstem, in the basal ganglia. The cerebral and hippocampal lesions develop later on by time. In the literature, they may call these focal abnormal signal intensities, they may call them as UBO, which means unidentified bright object. These unidentified bright objects are present in about 90% of patients with neurofibromatosis. And they are, as I have mentioned, they are hyperintense in the T1 and FLAIR images. They are of low signal in the T1. They do not enhance after contrast injection. They are not surrounded by edema. They do not exert any mass effect. And these lesions, by histopathology, they are not demyelinating lesions, and they are not an inflammatory response to other lesions. In the literature also, they said that some of these lesions in the T1 weighted image may appear of high signal, and they thought that this would be the sequelae of the presence of microcalcification in such lesions. The sensitivity and the specificity of focal areas of signal abnormalities in neurofibromatosis type 1 are, as you can see here. Then some of these lesions may appear with atypical criteria. Such atypical lesions may have mild mass effect. They may enhance with contrast material, and at that time you cannot distinguish these areas from the glial tumors. So usually the lesions are bright in the FLAIR image, as you can see here in the globus pallidus and in the thalamus. If you inject contrast material, they will not enhance. And you may also notice the presence of a cutaneous neurofibroma in the frontal area. In such a case of neurofibromatosis type 1, you see many of the focal abnormal signal intensities, and you see enlargement of the optic nerves, also tortuous appearance of the optic nerve, and you can see this is the site of the optic nerves in the coronal image in the suprasellar area. They are big, and these represent bilateral optic nerve glioma together with the unidentified bright objects in the brainstem, in the cerebellum, and in the basal ganglia. Then one of the manifestations is known as hamartomas. And by hamartoma, we mean that there are normal cells in an abnormal location. The hamartomas cannot be usually discriminated from the focal areas of abnormal signal intensity. Both appear of bright signal in the T1 and the FLAIR and the T2 weighted image. They are not surrounded by edema, they do not exert any mass effect, and they do not show any contrast enhancement. I'm sorry. Then how to discriminate the hamartomas from the focal areas of abnormal signal intensity? Actually, the only discriminative feature is in the size. I think that hamartomas should be relatively sizable compared to the focal areas of abnormal signal intensity. But the locations are almost the same, and the discrimination of hamartomas from gliomas is sometimes difficult, and you may use the MR spectroscopy so that you are able to differentiate these benign lesions from the glioma. Then if you look here and you see that there is an abnormal signal in the hippocampus on the left side and also on the right side. There are abnormal signal along the visual pathways bilaterally, and these lesions, as I mentioned in previous lectures, they may represent one of two. Either they are hamartomas or gliomas along the visual pathways. And I said previously, in order to discriminate between hamartomas and gliomas, you may inject contrast material. If no enhancement, think of hamartoma. If there is enhancement, and think of glioma. But the recent literature says that the lesions of low-grade types of gliomas may not show any contrast enhancement. Then, To be sure that you are dealing with hamartoma or glioma, you may have MR spectroscopy to be able to discriminate between both lesions, because glioma will progress by time, while the hamartoma may remain stationary for a relatively long time. Then, one of the hamartomatous lesions of neurofibromatosis type 1 affects the corpus callosum. And at that time, and you can see that the corpus callosum is relatively big and is thickened compared to the normal appearance of the corpus callosum. Hydrocephalus is one of the known criteria in patients with neurofibromatosis type 1, and the literature says that it is not rare, and it can be seen in about 1% of adults and 13% of children. It is usually of the obstructive non-communicating type, and they causes the possibilities of hydrocephalus in these patients include the presence of aqueduct stenosis, the presence of aqueduct web, the adhesions in the superior medullary velum, and some of the patients with neurofibromatosis type 1 may show dilatation of the ventricles with absence of symptoms. One of the causes of hydrocephalus is the presence of hamartomas in a strategic location, like this one, which is located near the aqueduct of Sylvius, intimately related to the posterior aspect of the third ventricle, which is compressed. Then you got dilatation of the lateral ventricles with distension of the temporal horns, denoting the presence of hydrocephalus. Epileptogenic lesions means that there are some lesions detected on MRI that can contribute to the seizures attacks in patients with neurofibromatosis type 1. The seizure frequency is higher in patients with neurofibromatosis type 1 compared to the other population. The prevalence is about 5%, and it increases by age. Then you may be able to detect an epileptogenic lesion, for example, in the region of the hippocampus, and this can explain the symptoms. And many times you can see you cannot see a definite lesion, but the patient is complaining of seizures. As the literature say, the seizures can be controlled by medical treatment. If you look here, and this is axial and coronal, axial T2 and coronal flare. The region of the hippocampus on both sides shows abnormal signal, and on the right side you got also loss of volume. And you know that these features are diagnostic of mesial temporal sclerosis, loss of volume and abnormal signal. Any one of these criteria is enough, but both are present here in this patient: abnormal signal and relative loss of volume of the right hippocampus, and this can explain the seizures attacks in this patient. Then the ocular manifestations are many. In patients with neurofibromatosis type 1, they include optic nerve glioma, sphenoid wing dysplasia, and periorbital plexiform neurofibromatosis. Patients with ocular lesions may present with orbital lesions may present by pulsatile exophthalmos, ophthalmos, visual impairment, and ocular proptosis and ophthalmos are related to increased intraorbital pressure, as I will explain. The literature indicates that because of the relatively common orbital manifestations in patients with neurofibromatosis type 1, they recommend ophthalmological assessment coupled by MRI examination every 6 months to guard against the development of ocular lesions and to prevent as much as they can the resultant complications. One of the common manifestations is the presence of sphenoid wing dysplasia. This means that the greater wing of the sphenoid, this is the greater wing of the sphenoid bone, and is absent on the right side. Then, because of the absence of the greater wing of the sphenoid, the temporal lobe, as well as the CSF, as well as the meninges, are able to herniate inside the orbital cavity. And this will result in increased intraorbital pressure and pushing of the globe anteriorly, resulting in proptosis. These sphenoid wing dysplasias are seen in about 10% of the cases with neurofibromatosis type 1. The greater wing may be hypoplastic or totally aplastic, and this will result in evident facial asymmetry. This lesion may progress on time and over time, and may result in exophthalmos, incomplete lid closure, corneal ulceration, and sometimes visual loss. Then in the era before CT and MRI, they used to diagnose sphenoid wing dysplasia from the plain X-rays of the skull. And they said that normally you see a line which is known as the innominate line going through the orbital cavity. But in cases of the sphenoid wing dysplasia, you cannot see this line, and you see what's known as the bare orbit. You see that the orbit is empty, and you may feel this in this plain X-ray, and also it's quite evident in this 3D reformatted CT image. Then the disease is well appreciated in the axial, coronal, sagittal CT scans. As you see here, there is dysplasia of the left greater wing of the sphenoid with consequent herniation of the contents of the middle cranial fossa, including the part of the temporal lobe, CSF, meninges, encroaching on the orbital cavity. And this is evident also in the coronal image and in the sagittal image. If you compare with the normal sphenoid wing, then you can see this is the normal appearance, but here you see the deficiency of the sphenoid wing. And this is what we mean by empty orbit sign or bare orbit sign. In the normal orbit, you can see the fissure, you can see the greater wing of the sphenoid, but here you are not able to see these structures because the greater wing is aplastic, and there is herniation of the temporal lobe, as you can see inside the orbital cavity. This is also well appreciated in MR images, axial T1 with contrast and the axial T2. You see that this is the normal greater wing of the sphenoid on the right side, but this wing is absent on the left side. And instead you see that CSF as well as part of the temporal lobe are encroaching on the orbital cavity. Sutural defects means that there is some rarefaction or defects in the calvarial bones, which these defects are usually seen in the posterior aspect of the skull, and according to the literature, they may be intrinsic bone development abnormality due to gene mutation, or maybe the sequelae of pressure by neurofibromas adjacent to the bone defect. But it happens many times Then you see the bone defect without any adjacent neurofibromas, and this is one of the diagnostic criteria of neurofibromatosis type 1. This patient is examined at the age of 8 years and at the age of 17 years, and you see that this part of the occipital and temporal bone is affected and thinned out, but later on it's totally absent. Then we came to the tumors, and as I said, the most common is the optic nerve glioma, which is commonly seen before the age of 6 years. And the rest of tumors will be also discussed. The optic nerve glioma is one of the findings in patients with neurofibromatosis, and it can also occur in patients without neurofibromatosis. But the bilaterality of optic nerve glioma may suggest the possibility of neurofibromatosis. And the gliomas of the optic pathways are also known to be frequently appreciated in patients with neurofibromatosis type 1 compared to other population. You know that the optic nerve passes through the optic canal and form the optic chiasm in the suprasellar area, then the optic tract, then the visual pathways ending by the visual cortex or the visual radiation in the occipital lobe. Then optic pathways glioma represents about less than 1% of the brain tumors, and it presents about 5% of tumors in the pediatric age group. Most of these tumors are seen before the age of 6 years, and as according to the literature, in spite that these lesions are benign, they are of low-grade type, they may be able to disseminate through the CSF. This is the visual pathway, the optic nerve, the chiasm, the optic tract, and the visual radiations. The affection of the visual pathways may result in vision, loss of vision, optic nerve atrophy, proptosis, and ophthalmoplegia. Large tumors may result in obstructive hydrocephalus if they affect the ventricular CSF pathways. Also, seizures may be encountered, hemiparesis, and precocious puberty. And this is what we can see in the MR. There are infiltrative lesions along the visual pathways, and these lesions are of low signal in the T1, high signal in the T2, and the flare. And if you inject contrast material, they will not enhance. And if you have the diffusion weighted images, they will not show diffusion restriction. As I have mentioned, that I said previously, if the lesions are not enhancing after contrast, consider hamartomas. If they are enhancing, consider gliomas. But the recent literature indicates that low-grade type of gliomas may not show contrast enhancement similar to hamartomas, and the only available way to differentiate between both is the MR spectroscopy. And this is another patient with visual loss and the skin rash. In the orbit, you see marked enlargement and tortuosity of the optic nerves. You got infiltrative lesions along the visual pathways. If you inject contrast material, the lesions will not enhance, but the optic nerve pathology will significantly enhance. And these patients had optic nerve glioma, bilateral optic nerve glioma, and of course the low-grade type of glioma along the visual pathways. Then Optic nerve glioma is one of the common brain tumors or head and neck tumors in patients with neurofibromatosis type 1, and is seen in about 20% of the cases. The glioma is usually of the pilocytic type, and they do not usually progress to the high-grade gliomas. You remember that glioma of the brainstem may be of the pilocytic type and may progress to glioblastoma multiforme after that. But this type of gliomas in the optic nerve will not progress to the high-grade type. These lesions will result in significant enlargement of the optic nerve and evident tortuosity of the nerve. If you inject contrast material, they will enhance they will show evident post-contrast enhancement. Then about 40% of optic nerve gliomas in neurofibromatosis type 1 will show decline of the visual acuity. And the decision of the treatment of optic nerve glioma will depend basically on the degree of affection of vision. The affection of vision is more likely in female patients in young age, and if the optic tract is involved, these are considered the risk factors for affection of the visual acuity. And in the very old days before the era of CT and MRI, they taught us that if you look to the optic nerve canal and you see that it is wider compared to the opposite side, and also you see erosions of the well-defined margin of the optic nerve canal, and you think that the canal or the optic nerve is involved by a tumor. But nowadays, we rely upon, of course, the CT and the MRI, which will show the tumor and will show the extent of the tumor through the optic nerve canal. And these tumors will enhance homogeneously according to the literature. And you are not able to discriminate the optic nerve through the tumor mass compared to the patient with meningioma, for example. In cases of meningioma, you see the optic nerve through the tumor because the tumor is arising from the sheath of the optic nerve, not from the fibers of the nerve itself. And this is an optic nerve glioma, axial T2 and the T1 post-contrast with fat saturation. You got the tumor is of low signal in the T1, high signal in the T2, and it will show significant post-contrast enhancement. This is an optic nerve glioma with follow-up 4 years after chemotherapy, and you got significant decrease in the size of the tumor and also significant decrease in the contrast enhancement pattern, meaning that the lesion is responding well to the chemotherapy. Then what is the difference between optic nerve glioma related to neurofibromatosis and the optic nerve glioma which is not related to neurofibromatosis? In cases of optic nerve glioma in patients with neurofibromatosis, you will see other stigmata of neurofibromatosis in the patient. And these tumors are usually confined to the optic nerve. And sometimes or many times they present by bilateral optic nerve involvement. While those with unrelated to neurofibromatosis type 1, they involve the chiasm in about 90% of cases. The tumor will go through the optic nerve canal into intracranially to affect the chiasm, and is more likely to extend beyond the optic pathways, and the tumor is larger and often have a cystic component on imaging. Thank you very much.